Thank you, Deven. Thank you, Ajanta Pharma, for this opportunity. So, I shall be speaking about neo drugs in medical management. Glaucoma is the second leading cause of irreversible blindness globally, and the Indian scenario, there are about 12 million patients with glaucoma. About 10% of them are blind. What is disturbing is 90% of the disease is undiagnosed. On one hand, we say that 90% of the disease is undiagnosed, but at the other end of the spectrum, there is a possible 50% overdiagnosis. So what does it mean? Like, the magnitude of burden is such that we need to create awareness in the community regarding the disease on one hand, and on the other, conduct CMEs and praise the general ophthalmologist how not to miss glaucoma at one end of the spectrum and not how to overtreat glaucoma. So, with this background, let us go and see the definition of medical management of glaucoma. It is defined as preservation of visual function adequate to the individual needs with minimal or no side effects for the expected lifetime of the patient without any disruption of his or her normal activities at a sustainable cost. So, based on this thing, we need to evaluate how the anti-glaucoma medications really act. Number one, they act at the inflow aspect. They reduce by reducing the production of aqueous at the ciliary body level, and at the other end of the spectrum, how they facilitate the outflow. Basically, most of the anti-glaucoma medications as of now, they concentrate through the uvea ciliary outflow, one medication being through the trabecular meshwork to a certain extent. So, what are the outflow facilitators? The outflow facilitators are prostamides, alpha-2 agonists, cholinergics, prostaglandins, and ROCK inhibitors, the newer drugs. And the inflow reductors are alpha-2 agonists, beta-1 blockers, and carbonic anhydrase inhibitors. In the limited 8 minutes time, I can only enumerate the glaucoma drugs that are available in our armamentarium. Just give a brief history of that. The good old pilocarpine to begin with, and how to assess these anti-glaucoma medications. We have to assess on these three parameters. Number one, efficacy. How much an anti-glaucoma medication is going to reduce the intraocular pressure for you. Second, what are its systemic and ocular side effects? And does it provide some sort of a bonus in form of neuroprotection or vasoperfusion? So, the good old pilocarpine, it acts by physical stretch and it cannot be wished away even in the current day practice. It has its own role. Then the onset of beta blockers in 1978 revolutionized the management of glaucoma. Still, timolol is considered the gold standard, and all the new glaucoma medications are compared to the efficacy of timolol. Then came dorzolamide in 1994, followed by latanoprost, and then the brimonidine with its dual action. Then came travoprost, which claimed endurance, and that was followed by bimatoprost, which claimed 35% outflow through the trabecular meshwork. So, the new kid on the block as far as prostaglandins are concerned is tafluprost. It also facilitates outflow facility through the scleral outflow. It claims hyperemia, the side effect being minimal. It increases the vascular perfusion and endurance, and it also claims a better diurnal control. Then coming to the fixed combination drugs, they offer more convenience, they improve compliance from the patient. There is a diminished risk of washout due to multiple drops as well as less exposure to the BAK. So if you see the combination medications that are available till a few years back, all the combinations were with timolol, and when timolol is contraindicated, we are stuck. So a new combination came into existence a few years back, that is brinzolamide and brimonidine, and this opened up a multitude of opportunities for us, so that we can just use 4 molecules of anti-glaucoma medication in just 2 bottles in just 3 drops a day. But just to, as a synopsis of all the anti-glaucoma medications in our armamentarium, we had prostaglandin analogs, we had beta-adrenergic blockers, alpha-adrenergic agonists, and carbonic anhydrase inhibitors. But the drawbacks of these medications, none of the currently available medications, that means I'm saying about 2 to 3 years back, address the underlying pathology. What is the underlying pathology in glaucoma? It is decreased outflow resistance through the trabecular meshwork. The beta-adrenergic antagonists and alpha-adrenergic agonists do not lower the IOP in the nocturnal period. Many patients were unable to tolerate one or more of these agents, and when all the 4 agents were used, still the target pressure was not reached. So thus there was a need for effective medication to lowering the, that is, you have to focus to lower the outflow resistance. And how do we do that? The need of the hour was agents with novel mechanism of action that is directed to lowering the outflow resistance through the trabecular meshwork, that are highly effective during both diurnal and nocturnal period, that is all through the 24 hours, and preferably with additional pharmacologic properties as by way of neuroprotection, and they should be well tolerated with minimal adverse effects. In this line, we present Rho kinase. How does Rho kinase pathways act? The Rho kinase acts by enhancing the intraocular pressure. Rho kinase acts by filtering the blood wound healing and scar formation, and they also act by the RGCs and the optic nerve damage. So if we can inhibit this ROCK pathway by way of introducing Rho kinase inhibitors, what do? They decrease the aqueous humor outflow resistance, they provide some sort of a neuroprotection, and they increase the ocular blood flow. By altering the cellular components of the trabecular meshwork and the Slem's canal, the ROCK inhibitors decrease the resistance in the trabecular meshwork outflow pathway and promote reduction of IOP. Then ROCK pathway inhibition has shown to enhance the axonal regeneration, and large population-based studies suggest that lower ocular blood flow and perfusion pressure are a risk factor for the incident development of glaucoma and progression of the disease, and increase in ocular blood flow by causing vascular smooth muscle relaxation leads to vasodilatation and some sort of a vasoperfusion. So ROCK inhibitors potential to reduce scarring after glaucoma surgery. As I said, the ROCK pathways, they help in transdifferentiation of fibroblasts into myofibroblasts. And what the ROCK inhibitors do, they serve as a potent anti-scarring agents via inhibition of transdifferentiation from T1 fibroblasts to myofibroblasts. The studies have also shown the positive effects of Rho kinase inhibitors to control corneal endothelium. They enhance the adhesion of endothelial cells, and the ROCK inhibitors, they also help in protecting the retina and they have a role in diabetic retinopathy and macular edema control. So with this background of ROCK inhibitors, we introduced netarsodil and ripasodil. Netarsodil basically lowers IOP by 3 mechanisms. It relaxes the trabecular meshwork and increases the outflow, lowers episcleral venous pressure also. It has a role in reducing the fluid production. And netarsodil was seen to have an equal reduction of intraocular pressure both at a lower basal level and at the higher base. Less than 26 and over 26, it had the same potential to reduce the intraocular pressure compared to the PG analogs. This study was done with latanoprost, which controlled intraocular pressure 1 millimeter more at the higher end of the spectrum, but netarsodil had a same role in reducing the intraocular pressure. Similarly, when it was compared to timolol at higher spectrum of intraocular pressure, timolol had a better role, but netarsodil had a uniform role in controlling the intraocular pressure. The 3 most common ocular side effects that are associated with netarsodil is hyperemia, conjunctival hemorrhage, and cornea verticillata. So when can we use this molecule netarsodil as a monotherapy in patients as an adjunct agent, especially add to a prostaglandin? And recently studies are going on, and a launch with a combination of latanoprost and netarsodil is on the horizon to increase the patient compliance, like just 1 drop a day and after glaucoma surgery, as we have discussed, and then as another medical option to help delay or defer glaucoma surgery, especially when you are using maximum glaucoma medication. You need a little more drop before you plan for surgery. These molecules have a role. Now coming to ripasodil, the last molecule that I am discussing, it also acts by lowering the outflow resistance. When compared to a placebo, it had significant efficacy lowering the intraocular pressure, had a better diurnal control, and like other anti-glaucoma medication, more the basal intraocular pressure, better the action of ripasudil. So findings of these clinical studies showed that ripasudil is a promising IOP lowering medication with significant IOP reduction after instillations day and night in patients with open angle glaucoma and ocular hypertension, and ripasudil showed sustained IOP lowering effects throughout the study period, both at 3-month and 1-year duration for both monotherapy and additive therapy. The contraindications were only hypersensitivity, adverse effects, just one minute. Adverse effects, most of the conjunctival hyperemia findings were transient and the dosage is BD. And the last slide, ripasudil has potential to fulfill the need of the hour, target disease pathology, maximal IOP reduction within 2 hours, effective day and night control, effective monotherapy and combination therapy, sustained effect up to 52 weeks, effective in patients not responding to maximal therapies, appropriate medication for inflammation-associated ocular hypertension, additional beneficial pharmacological properties, and acceptable safety profile. Thus, promises to have an edge over other conventional therapies. Thank you for a patient hearing.
Thank you, sir. Thank you. That was really comprehensive and exhaustive. I repeat to the audience, please have the questions and we'll take them at the end. We have the pleasure now, Zoom link de dena. We have the pleasure now to have the oration of Dr. Leon Yu, who's our keynote speaker. And welcome, Dr. Yu. And we are very eager to listen to your talk on MIGS. It's in the nascent stages in India. So hopefully the audience, after listening to your talk, will be more motivated. Welcome. Go ahead, sir.
Thank you very much. Can you hear me okay?
It's all good. Thank you.